Hello, my name is Quentin Broussard. I'm Assistant Professor of Clinical Sciences at California Health Sciences University, and today we will be discussing distributive shock. And the reason why we're discussing distributive shock today is, like hypovolemic shock, distributive shock also involves many different treatment modalities such as fluid resuscitation, as well as vasopressor administration potentially to improve adequate tissue perfusion. And it's important for pharmacists to be aware of the different fluid options that are available, as well as the different vasopressor options that are available in order to treat distributive shocks. Our objectives today will be to define distributive shock. We're also going to go back and review vasopressor receptor pharmacology that you may have gotten in your pharmacology class. Compare and contrast vasopressor agents, and then we're going to use everything that we've learned from hypovolemic shock as well as the vasopressor agents to apply concepts of fluid resuscitation and vasopressors to treat sepsis and septic shock, which is a type of distributive shock. So, like always, we'll start out with case. AF is a 72-year-old male presenting to the ED with sepsis as a result of pneumonia. He presents hypotensive with a cuff blood pressure of 70/40. An A-line was placed, resulting in a blood pressure of 76/46, so not much better. His heart rate is 88 beats per minute. Upon admission, AF's lactate is 4.2 millimoles per liter. He reports he has not urinated in the last 48 hours. The team would like to start fluid resuscitation. Which of the following is most appropriate to initiate at this time? Albumin, D5W, hydroxyethyl starch, or normal saline? The next question is, after appropriate fluid resuscitation with the choice you just selected in question 1, AF remains hypotensive with an A-line blood pressure of 73/42. Which of the following would be most appropriate to initiate next? Dopamine, epinephrine, norepinephrine, or vasopressin? And the last question is, what is the mechanism of action and the corresponding action of the choice selected in question 2? Is it alpha-1 and mixed beta agonist, inoconstriction, dopamine receptor agonist, diuresis, pure alpha-1 agonist, bronchodilation, or a vasopressin receptor agonist, vasodilation? After this talk today, I hope that you become confident in answering each of these questions. So, with the last talk, we talked about hypovolemic shock and how hypovolemic shock is loss of plasma or blood volume from the circulation. As you can see in these little diagrams here, this is the heart, and this is essentially your vasculature. And the reason for patients to be in hypovolemic shock is the loss of plasma or blood volume. Today's focus will be distributive shock, which is essentially vasodilation of the blood vessels. I used to have a preceptor who would say whenever we were treating shock, he would always ask the question, is it a volume problem, is it a pump problem, or a vascular tone problem? So, in terms of hypovolemic shock, we talked about volume being the problem, and we appropriately fluid resuscitated those patients that we discussed. In terms of cardiogenic shock, it is the pump that is the problem, or the heart that's the problem. And that's actually going to be a topic we talk about whenever we talk about decompensated heart failure. But let's put that on the back burner for just a little bit, because today's topic is distributive shock, which is essentially a vascular tone problem, resulting in vasodilation and hypotension as a result of that. So, like I said, distributive shock is shock resulting from the periphery. So, as we saw in the picture over here, there's peripheral vasodilation that is occurring that eventually will cause hypotension in a shock state. A lot of times, distributive shock is secondary to the release of inflammatory mediators, such as within sepsis and anaphylaxis. or it may be due to injury, as is with neurogenic shock, because patients may have some type of spinal cord injury, for example, and the neurons innervate the different blood vessels that are in the body, and they tell them whether or not to constrict or to dilate. In neurogenic shock, because you have a spinal cord injury, that communication may not be happening properly, and as a result, you may actually have vasodilation, and as a result of distributive shock. Distributive shock, as we discussed, is essentially a decrease in vascular tone. And what this results in is a decreased systemic vascular resistance, or a clamping down of the vasculature. So basically, these patients are very vasodilated in the periphery. Now, whenever you compare the different types of shock, each of them has all their different cardiac parameters as well as their hemodynamic parameters that they have characteristic to just them. So whenever we talked about hypovolemic shock, we talked about a little about CVP and pulmonary arterial occlusion pressure, and how CVP is essentially the pressure returning back to the heart from the venous circulation. And this is decreased because of the volume or lack of volume associated with hypovolemic shock. And because you have a lack of volume, you're not able to output as much blood from the heart, resulting in a low cardiac output. And your body tries to compensate for this by clamping down on the vasculature or increasing systemic vascular resistance. Now, in distributive shock, which sepsis, as we said, was a type of distributive shock, you can be either hyperdynamic or hypodynamic. Hyperdynamic, essentially, the big difference here is that your cardiac output is increased, because whenever you vasodilate, your body will want to compensate by pumping more blood out to the vasculature as a result of your vasodilations to maintain blood pressure. And that is how sepsis is in most cases. Now, you also have sepsis in the context of patients who may have some cardiogenic element to their septic shock. And those patients tend to be hypodynamic, or more appearing like a cardiogenic shock, as we see here. So I know that these arrows may not make as much sense right now, but we will do an exercise where we'll try to kind of clear up the confusion between each of these different parameters. So don't be confused about these just yet. Hold on, and we'll talk about these a little more whenever we actually do a lab exercise over them. In terms of distributive shock treatment, so like any other type of shock, particularly like the hypovolemic shock, we always want to correct the underlying cause if possible. So if it's septic shock, we're going to talk a little bit about how sepsis is caused by infection, and you ideally want to treat infection with antimicrobial therapy. Now, you also will treat distributive shock with fluids, just like you did in hypovolemic shock, and that's with isotonic crystalloids such as NS or LR. However, because this is not necessarily a hypovolemic shock and it's a distributive shock, fluids may not do the trick completely, and as a result, you may actually need vasopressor agents to try to control the vasodilation that is occurring as a result of distributive shock. In terms of vasopressors, it's important for us to first understand where our different vasopressor receptors are at, and our different alpha and beta receptors, as well as vasopressin receptors are at, as well as dopaminergic receptors, and how they actually work. So as you see, they are all bolded here. And again, we will do an exercise in class to kind of clarify some of these things. But these are things that you will need to know in order to understand how the different vasopressors work. So in terms of your alpha-1 and your alpha-2 receptors, your alpha-1 and your alpha-2 receptors are primarily found on your peripheral vascular smooth muscle, so essentially your vasculature. And these are responsible whenever you agonize them or activate them, they will cause vasoconstriction. So we have some agents here that activate alpha-1 primarily and will cause vasoconstriction as a result of that, therefore boosting blood pressure and MAP. We also have beta-1 receptors, which are primarily found on the heart, and beta-2 receptors, which are primarily found on the lungs. And the way to remember these is that beta-1, you have one heart. Beta-2, you have two lungs. With your beta-1 receptors that are found on the heart, you have a result of positive chronotropy, positive inotropy, and positive dromotropy as a result of activating beta-1 receptors. Positive chronotropy means that your heart rate will increase. Positive inotropy will mean that your cardiac output will increase, or your contractility will increase, essentially. And positive dromotropy means that your conduction will actually increase, so increased conduction. So that's what each of those terms means. Beta-2 receptors, as we said, are found on the lungs, but it's also important to note that they're found on vascular smooth muscle, so similar to the alpha-1 and the alpha-2 receptors. So with the lungs, whenever you activate a beta-2 receptor, you actually will cause bronchodilation, and the agents to think about with this are obviously your beta-2 agonists, such as albuterol and salmeterol. Whenever you activate the beta-2 receptor in the vasculature, however, it's a little different than when you activate the alpha-1 and the alpha-2. The beta-2 is responsible for vasodilation, so it actually will cause vasodilation versus vasoconstriction. And we won't talk about this a lot today, but we will talk about this more whenever we talk about decompensated heart failure, because there are some agents such as Dopamine, which will actually potentially cause this vasodilation effect. The other important receptors I want you to know about are the vasopressin receptors, and those are V1A, V1B, and V2. For our purposes, we're just going to focus on V1A and V2. V1A is found on vascular smooth muscle, and like the alpha receptors, is responsible for vasoconstriction. V2 is found on the renal collecting duct and is responsible for water reabsorption. We also have the D1 and the D2 receptors, which are dopaminergic receptors that are found in all different places of the body. And they are responsible for increased renal and mesenteric perfusion and diuresis and natriuresis, and that will be associated with dopamine. These receptors you won't necessarily need to know about as much because their mechanism of action is slightly more complicated than the other receptors. I do want you to know about these 5 bolded receptors here, where they're located and what their agonism action is, though, because that will be important in determining what agent you actually use. So, to give you a little bit of an idea of what these receptors actually look like. So, this is an alpha-1 receptor on the left side here. And similar to signal transduction pathways that you probably learned about in your biochem and pharmacology classes, the net effect of activating an alpha receptor in the periphery is vasoconstriction, as you see here, as we talked about earlier. Now, depending on which type of beta receptor you activate. Now, if you're activating a beta-1 receptor on the heart, which you'll actually go down this pathway with, you will actually see positive chronotropy or increased heart rate, positive inotropy or increased contraction, and positive dromotropy, which is not listed here, which is increased conduction. That's for beta-1 receptors, so this left side is beta-1. On the right side, you see here, when beta-2s are activated in the periphery, they actually result in vasodilation. Now, I don't want you to get caught up in the sequence of all these different events that happen. I just want you to know where the receptors are, what happens whenever you activate them, and what is the net effect, essentially, which is pretty much what we showed on the last slide. This is more of a visual representation of what actually goes on in the background. So, as I stated before, we have many different vasopressor options that are available, and they all do different things. We have norepinephrine, epinephrine, phenylephrine, dopamine, and vasopressin. So the first drug we'll talk about is actually norepinephrine. So norepinephrine is an alpha-1 agonist as well as a mixed beta agonist. So it actually will activate both the beta-1 and beta-2 receptors. And primarily its action is more on alpha-1 than anything compared to beta-1 and beta-2. And I like to think about this agent as an inoconstrictor. So ino means contraction, constrictor means constriction of the peripheral vasculature or the blood vessels in the vasculature. As I said, it's better at vasoconstriction versus its beta effects. So I like to think about this agent primarily as an alpha agent, though it does have beta effects. And as a result, it does increase systemic vascular resistance, or that clamping down of the vasculature. As you see here, these are the typical dosing ranges of norepinephrine, which you will not be responsible for knowing. All you need to know in regards to the dose range is that you need to titrate to your goal map. And typically your goal map is going to be ideally above 65 in most cases. Some adverse effects of norepinephrine specifically is that it can result in tachydysrhythmias as a result of its action on beta-1 receptors, which are, again, on the heart. And this can result in supraventricular tachycardias due to the beta-1 effect. And as a result of this, if you develop these tachydysrhythmias such as SVT, you'll want to titrate this medication off. You also may get peripheral or digital ischemia from this medication as a result of the clamping down that occurs whenever you use this medication on the vasculature. Because remember, your body always tries to prioritize your heart and your brain in any scenario. So as a result, you may not be getting as much perfusion to your digits as well as your extremities. And that can actually result in gangrene eventually. You may get hypertension from this agent as a result of it activating your alpha-1 receptors. And you may get reflex bradycardia that may occur after activating the alpha-1 receptors initially, because typically these patients may present as tachycardic as a result of a compensatory response to try to increase blood pressure. So whenever you actually infuse norepinephrine, that effect actually reverses and you may get reflex bradycardia. The next agent we'll talk about is epinephrine. Like norepinephrine, it is also an alpha-1 and mixed beta agonist. Again, it's an inoconstrictor. However, with this agent, it's actually more ino than constrictor in most cases, because it does provide more beta-1 action compared to norepinephrine. So I like to think about this drug as in terms of contracting the heart more, but it does still vasoconstrict. Its dosage range is listed here. Again, you want to titrate this one to goal map, ideally probably greater than 65. And your adverse effects from this drug, because you activate the beta-1 receptor, is ventricular arrhythmias as well as severe hypertension as a result of activating alpha-1 receptors. Phenylephrine is different than epinephrine and norepinephrine in that phenylephrine is a pure alpha-1 agonist, and it will only vasoconstrict. It has no beta-1 or beta-2 activity. It does not act on the heart at all, and that's important to remember. As a result, it increases systemic vascular resistance just like epinephrine and norepinephrine do. Its dosage range is listed here. Again, you want to titrate to your goal map for this one, greater than 65. Its adverse effects include reflex bradycardia, as we talked about earlier with norepinephrine, hypertension, and then you may also see tissue necrosis with this agent as well as the other vasopressors. And you can actually treat this with phenylephrine, which is an alpha antagonist. So essentially this tissue necrosis is occurring as a result of extravasation. Phenylephrine will actually antagonize alpha and cause vasodilation to try to relieve this tissue necrosis and extravasation. Dopamine is the next agent that we'll talk about. Dopamine is probably the most complicated of the vasopressor agents in that it actually can act on alpha-1, both of the beta receptors, as well as a dopamine receptor. And the action actually depends on the dose that you will infuse into a patient. So at lower doses, you predominantly get a dopamine effect or dopamine agonism effect or dopaminergic agonism effect whenever you're at doses of 0.5 to 3 mics per kilo per minute. And this results in increased mesenteric and renal perfusion. This is what some clinicians will call renal dose dopamine. At doses of moderate dose of 3 to 10 micrograms per kilo per minute, you actually get beta-1 agonism primarily, which results in increased inotropy and chronotropy, as well as dromotropy, which we discussed earlier with some of the other agents. At doses of 10 to 20, which are high doses of dopamine, you get primarily alpha agonism. So essentially, the way to remember this is that it kind of goes in reverse alphabetical order. So you have your dopamine or D1 and D2 agonism here, your beta or your B1 receptor here, and your alpha or A1 receptor here. So that's how you remember, or that's how I remember which of the receptors go with which dosage range. So it's important to remember these dosage ranges because depending on what dose you actually give, that will determine what effect you get. And as a result of that, it's important not to titrate to effect with this agent unless you're actually titrating within that range. So it wouldn't necessarily be appropriate, say if you wanted a beta effect and say if you were at 5 mics per kilo per minute, to titrate it all the way to 15. It wouldn't necessarily give you that predominant beta effect anymore. It would actually give you more of an alpha effect. So that's very important to know. Adverse effects of dopamine include severe hypertension as a result of the alpha effect, ventricular arrhythmias, which will be very important whenever we talk about septic shock a little later, because whenever they compared it to some of the other agents like norepinephrine, there was actually more arrhythmia risk, and peripheral or digital ischemia, again with this agent as well as many of the other vasopressors. The last vasopressor we'll talk about is vasopressin. Vasopressin acts differently than the other vasopressors in that it does not activate alpha-1 and alpha-2 receptors. It does activate V1A, V2, and V1B receptors. And in terms of shock, the ones I want you to remember are the V1A and the V2 receptors. And these will actually help vasoconstrict as well as retain body water. It will also increase systemic vascular resistance. The standard dose for this medication is 0.03 units per minute, IV continuous infusion. This agent should not be titrated. Though I have seen it been done in practice, it doesn't really have much of an effect either which way. However, there is only one standard dose for this medication, and as a result, that's why it's not titrated. This agent can actually work synergistically with other vasopressors because the pharmacology is different compared to the other vasopressors not using alpha or beta. An important thing to note about vasopressin is that vasopressin action is preserved during hypoxic and acidotic conditions like sepsis. So whenever you have a patient who is septic, this agent is actually recommended second line after norepinephrine for septic shock, which we'll talk about shortly. Its adverse effects include hypertension as a result of the vasopressin receptor effect. Whenever you compare all the different vasopressor activities, it's important to have an idea of which one activates which receptor more. So I don't want you to necessarily memorize all of the pluses here, which stand for activity for each of these receptors, but I do want you to know regarding each of the individual slides that I showed you earlier, regarding which one will act primarily more alpha or beta, which one will activate this receptor or that receptor. That's what I primarily want you to know about. So I don't want you to necessarily know that norepinephrine has 5 pluses. But I do want you to know norepinephrine has more of an alpha effect than a beta effect. And epinephrine, though it has more pluses here for the alpha effect, remember we talked about it primarily acting as a beta agent. And this beta agent's actually seen more often than this alpha, even though it does activate this alpha receptor more. Phenylephrine we talked about being a pure alpha-1 agonist with no other activities. Dopamine we talked about how the dose, the action would depend on the dose. And vasopressin, we talked about the vasopressin receptor, which is labeled VA here. What do you want to monitor whenever you monitor these vasopressor agents? So what are we actually looking for? So we're looking for blood pressure, essentially, is our first thing that we want to do. Our goal is to get our patient's blood pressure up, as well as their mean arterial pressure, which you will remember is 1/3 systolic blood pressure plus 2/3 diastolic blood pressure. We also want to monitor patients' heart rates, because some of these agents do act on the beta-1 receptor and can speed your heart rate up. We want to monitor an electrocardiogram or ECG or EKG to monitor the different cardiac rhythms that the patient may have, because a lot of these different agents will actually cause ventricular arrhythmias or other type of arrhythmias, which may be dangerous. We want to monitor patients' urine output on these medications. Are we clamping down too much on the vasculature to where we're not getting enough blood flow to the kidneys now? We want to monitor central venous pressure, because remember, ideally first we should have fluid resuscitated the patient. Is what we're doing vasopressor therapy-wise appropriate, or do we need to give more fluid to the patient? We need to check blood flow to the extremities. Is the vasopressor clamping down appropriately and increasing blood flow to the extremities to prevent potential digital ischemia or gangrene? If we have them available, which we may not, depending on what kind of access device we have that we discussed in the hypervolemic shock lecture, we may want to look at systemic vascular resistance and SVO2 or SCVO2, as well as cardiac output and cardiac index. So now that we kind of got a little bit of information about the different vasopressor agents and the different pharmacologies of vasopressor agents and what they actually do, let's actually apply them now to a disease state or disease states known as sepsis and septic shock, which is a type of distributive shock, which will cause vasodilation. To give you a little bit of background, just so that you know exactly how the vasopressors and the fluids will play a role in sepsis. Sepsis pathophysiology is highly complicated. In order to have sepsis, you have to have some type of infection. That infection will eventually progress, and then that infection can potentially lead to inflammation that leads to host tissue damage. That will then eventually lead into an anti-inflammatory response, which activates different leukocytes or white blood cells. And eventually, your leukocytes are battling against this damage from the infection that eventually the control of the inflammatory process is lost. Essentially, your immune system cannot overcome the underlying infection, and you're not able to kill the pathogen. As a result of that, systemic inflammatory response syndrome occurs, which essentially is related to sepsis in that these inflammatory responses can manifest as anything from a high heart rate to a high respiratory rate to a high temperature, which may occur with SIRS. And as a result may actually result eventually in hypotension as a result of vasodilation from all of the inflammatory responses that are going on with the damage to the host tissue damage. And then as a result of that, you may get a diagnosis of sepsis or septic shock. This picture just kind of shows you the general gist of what actually goes on. Essentially, here you have some type of pathogen. It eventually goes down and causes its damage. You have different inflammatory responses that are occurring immunologically with TNF-alpha and interleukins, as well as different other cascades that are occurring, such as neutrophil activation and platelet activation. Those go and do endothelial damage, and then eventually an inflammatory response occurs and you develop sepsis. That sepsis can then eventually lead to septic shock with or without organ failure. And that septic shock, just like hypovolemic shock, may result in a low blood pressure. So how does sepsis present? Sometimes these patients will have an altered mental status or an encephalopathy as a result of sepsis, particularly in older elderly patients, which are a little more sensitive to changes in oxygen delivery, which sepsis, as a result of the vasodilation that occurs, you're not getting as much blood to where it needs to go throughout the body, similar to hypovolemic shock, except this pathophysiology is based on vasodilation, not as much on hypovolemia. You may get systemic inflammatory response syndrome, which comprises of elevated heart rate, elevated temperature, elevated respiratory rate, or an elevated white blood cell count. Hemodynamic stability is one of the biggest things to look for in terms of diagnosing septic shock specifically. So you may have hypotension or tachycardia. However, with the new guidelines that have come out recently, which we'll talk about with sepsis, diagnosing sepsis is a little different now. So hemodynamic instability, however, is an important factor to look at. You may get acute respiratory distress syndrome, which actually results from a metabolic acidosis that's generated by a sepsis, from lactic acidosis, and the compensation, as we remember, for a lactic acidosis or a metabolic acidosis is a respiratory alkalosis, which causes respiratory distress. You may have acute kidney injury, which may result in oliguria or anuria, as a result of lower perfusion to the kidneys. You may get DIC, which is disseminated intravascular coagulopathy, as a result of the utilization of a lot of the immune system, resulting in thrombocytopenia. And as a result of patients being thrombocytopenic, they may actually develop hemorrhage in their GI tract or other places. You may get acute liver injury from poor perfusion to the liver. This is also known as shock liver. Lactic acidosis, which we've talked about being an anion gap metabolic acidosis, as well as many others. So how do you diagnose sepsis? There was a paper published back in February 2016, which is the third international consensus definitions for sepsis and septic shock, also known as Sepsis 3. And they redefined the definitions for sepsis and septic shock. These are just listed here so that you can have the context for knowing about sepsis and septic shock. What I really want to emphasize whenever we're talking about sepsis and septic shock is the fluid treatment and the vasopressor treatment. So in terms of sepsis, sepsis is a life-threatening organ dysfunction caused by dysregulated host response to infection. So you have to have some type of infection with organ dysfunction, essentially. Septic shock is a subset of sepsis in which particularly profound circulatory, cellular, and metabolic abnormalities are associated with a greater risk of mortality than with sepsis alone. Some of the sepsis treatment fundamentals that you see here are to obtain blood cultures first if possible, or any other cultures that may be relevant to your patient's infection. Prompt administration of empiric antimicrobials, which you have not necessarily covered in this patient care course, and I'm not going to expect you to know, but this is just here for your reference. What I do want you to know, however, is that you do fluid resuscitate these patients if they are hypotensive, or have a lactate greater than 4 millimoles per liter. After fluid resuscitation, you may actually administer vasopressors if the patient's hypotensive and not responsive to fluids. You may need corticosteroid administration if the patient's not responsive to vasopressors, and inotropes if there's myocardial dysfunction or a cardiogenic component to this septic shock, as well as other supportive care modalities. In terms of sepsis, back in 2012, they developed sepsis bundles that essentially were the gold standard for treating sepsis. And they had a 3-hour bundle and a 6-hour bundle, which are still used commonly in practice today. So the 3-hour bundle is to measure a lactate level, which lactate is a measure of anaerobic metabolism. The second thing is they want to obtain blood cultures prior to administration of antibiotics or antimicrobials, administer broad spectrum antibiotics within 1 hour, and then if you have a patient that's hypotensive or a lactate greater than 4, which we mentioned earlier, you actually want to give these patients crystalloid fluid in the amount of 30 mils per kilo. And that's the important part from this slide that I want you to get, as well as measuring the lactate level. If the fluid resuscitation does not completely work, or if patients are not very responsive to it, you may apply vasopressors to the patient to get a mean arterial pressure greater than 65, if possible. In the event of persistent arterial hypotension, despite volume resuscitation or an initial lactate greater than 4, they recommended to measure CVP or an SCVO2. And their goal CVP was above 8, ideally between 8 and 12. And their SCVO2 was greater than 70% or equal to 70%. The last thing they want you to do in these bundles is to remeasure a lactate if the initial lactate was elevated. So if the initial lactate was above 2 or above 4 even, then they would want you to remeasure a lactate to see if it went down in 2 hours. Now, the 2016 guidelines are a little different because they don't specifically mention the 3 or 6 hour bundles used in the 2012 guidelines. But however, just because these bundles are eliminated, the guidelines still mention many of the bundle components still having to be done. The exception is step 6, which was measuring the CVP and the SCVO2, though many clinicians will still do it. They recommend in the 2016 guidelines about monitoring different parameters to assess fluid responsiveness, such as blood pressure, urine output. They still mention CVP and SCVO2, lactate clearance, passive leg raising, which may actually show response to fluid, as well as many others. So again, these are the 3-hour bundle elements. The first one we're going to focus primarily on is measuring lactate levels. So again, I did mention that lactate was a byproduct of anaerobic metabolism, and it is used as a diagnostic and prognostic tool in sepsis. Ideally, we want to achieve a lactate clearance of 20% over 2 hours. So when the patient comes in, they get their sepsis bundle, they draw a lactate. And if the lactate is high, what we want to do 2 hours later is draw another lactate after we've given them some fluid resuscitation as well as some antibiotics to see if they are actually clearing out their lactate or if the lactate is getting worse. If the lactate is getting worse, that means the shock may be getting worse. If the lactate is getting better, that means the shock might be getting better. There are some caveats to interpreting lactate levels. Lactate may accumulate in hepatic dysfunction, so specifically liver disease or cirrhosis. Therefore, it's not necessarily reliable always in this patient population. Also, epinephrine may actually increase lactate levels if epinephrine is given. And this is a result of increased lactate production that is stimulated via epinephrine. The other element I want to talk about is the 30 mils per kilo crystal weight for hypotension or lactate greater than or equal to 4 millimoles per liter. In terms of initial fluid resuscitation for sepsis patients, the guidelines recommend that the patients should get 30 mils per kilo of IV crystal weight fluid within the first 3 hours. If they are hypotensive, which means a MAP of less than 65 or a systolic blood pressure less than 90, or if they have a lactate greater than 4. For this recommendation, you should only use isotonic crystalloid fluids, so NS or LR, which is very similar to what we talked about in terms of treating hypovolemic shock. You may also use albumin in addition to crystalloid if the patient requires a substantial amount of crystalloid, so more than the 30 mils per kilo traditional amount. And hydroxyethyl starches, as we mentioned in hypovolemic shock, are not recommended due to their adverse effect profile and compared to albumin. This chart is very important to know. What I want you to get from this chart is that no matter what the indication or no matter what the patient's background is, all of these patients will still get 30 mils per kilo if they have hypotension or a lactate greater than 4 here. That is the most important thing I want you to get from this slide. In addition, I want you to realize that all these different other parameters can be measured to look at fluid responsiveness. Now, in terms of the surviving sepsis bundles and the 6-hour bundle specifically, it's important to apply vasopressors if you don't meet your initial fluid resuscitation goal. We also have the goal to measure CVP and SCVO2 and remeasure a lactate. So we're going to focus primarily on vasopressors since we just learned about vasopressor support in general with the different vasopressor agents and their pharmacology and how that applies to sepsis and septic shock. So vasopressor support and septic shock. So in general, you should always give patients fluid resuscitation first, prior to giving a vasopressor agent. However, if they don't become normotensive after an initial fluid resuscitation attempt, you may need to start a vasopressor agent. Typically, norepinephrine is recommended first line to target a MAP of greater than or equal to 65. Now remember, in septic shock, one of the big problems is vasodilation, and norepinephrine has that alpha effect to combat that vasodilation, though it may not work in everyone. And norepinephrine is where most of the data is concerning sepsis and septic shock, and that's why it's first line compared to another alpha agent such as phenylephrine. Now, if your patient is still hypotensive on norepinephrine after you've gotten fluid resuscitated with a 30 mils per kilo, vasopressin is recommended to be added to norepinephrine as a second-line vasopressor if the MAP goal cannot be attained. So essentially at this point, then you're having patients on norepinephrine and vasopressin. If at that point your patient is still hypotensive, epinephrine may be added on if patients are still hypotensive. However, from a clinical practice standpoint, I like to see ideally what that patient's real etiology of shock is at that point, to see whether or not they're actually, still primarily in septic shock, or if there's a cardiogenic component to their shock. You may consider switching norepinephrine or epinephrine to phenylephrine if tachyarrhythmias occur with norepinephrine or epinephrine. So these are essentially your supraventricular tachycardias, your other ventricular tachycardias, and your other tachydysrhythmias. In general, dopamine is recommended last line for vasopressor support in septic shock. Phenylephrine does not have any recommendations for vasopressor support in septic shock, so there's nothing for or against phenylephrine. But dopamine is recommended last line. The reason why dopamine is recommended last line is because whenever they compare norepinephrine to dopamine in sepsis, particularly severe sepsis, which we won't really talk about the definition of. Whenever we looked at the study populations, whenever comparing norepinephrine to dopamine, we actually saw worse outcomes associated with dopamine, such as short-term mortality, serious adverse events such as supraventricular tachycardia, and severe adverse events such as ventricular tachycardias. And all these can relate to mortality. So norepinephrine is first line, and that is why dopamine is last line for sepsis and septic shock. In regards to inotropic support, so you may have a patient who comes in with septic shock or what you think is septic shock. However, they may have something like a pre-existing heart failure or some kind of cardiac instability that pre-exists. And in some of those cases, you actually may have to use dobutamine, which is a mixed beta-1 and beta-2 agonist, in patients who actually show evidence of persistent hypoperfusion despite adequate fluid loading and the use of vasopressor agents. So this agent is typically used after at least 2 vasopressors are already on. And those 2 vasopressors are typically norepinephrine and vasopressin. And there is evidence that the shock has some kind of cardiogenic component. So that can be a low cardiac output, a low cardiac index, or a low SCVO2. And that's essentially a definition of what is considered to be hypodynamic. So what is important to know from this slide, in addition to using dobutamine after norepinephrine and vasopressin, if you have a low cardiac output or cardiac index or low SCVO2, is what are the ranges for cardiac output, cardiac index, and SCVO2? Well, anything below 4 to 8 for cardiac output, anything below 2.5 for cardiac index, and anything below 70 for an SCVO2 will automatically qualify you to be a cardiogenic component. These bolded numbers are numbers you should know and have memorized. In regards to what happens whenever your patient has refractory shock, so you've been on a couple of vasopressor agents already, norepinephrine and vasopressin. What can you do now in addition to your vasopressin agents? You can also give corticosteroids in the form of IV hydrocortisone. The thought behind this is that IV hydrocortisone is thought to be an anti-inflammatory agent. And that's why it may potentially be used in septic shock with good results. However, the data on this is not that great. However, the sepsis guidelines do recommend to use it to treat septic shock patients if adequate fluid resuscitation and vasopressor therapy are unable to restore hemodynamic instability. It's typically dosed at 200 milligrams per day, which equates to an actual dosing of 50 milligrams IV every 6 hours. Again, this is done typically after 2 vasopressors are currently being administered. This is another important chart for you to memorize and understand, as well as the little notes here. These are also important to understand as well. So, in terms of vasopressor use in septic shock, the first thing you want to do after you give fluid resuscitation is to give norepinephrine. If norepinephrine doesn't work, add vasopressin. If vasopressin and norepinephrine don't work together, as you see the little star here, you can add IV steroids, hydrocortisone, as well as start epinephrine here if your MAP is still not achieved. However, remember, if you have a low cardiac output cardiac index or low SCVO2, you can do dopamine here. If you're still not meeting goal, you may use phenylephrine as a fourth line agent after the first three vasopressor agents, norepinephrine, vasopressin, and epinephrine. However, phenylephrine does not have any recommendations in the surviving sepsis guidelines. Dopamine can be used as a niche vasopressor in patients who have sinus bradycardia. In those cases, you might want to use the beta dose of dopamine, which is 3 to 10. Remember to consider phenylephrine if you have severe tachydysrhythmias that occur with norepinephrine. And you can even do this in substitution of epinephrine as well. Other supportive care options that you may do for patients that are septic, which we're not going to focus primarily on, include blood product administration, mechanical ventilation if they have respiratory depression, sedation and analgesia for pain and sedation if they're on the vent especially, glucose control because these patients become very hyperglycemic, renal replacement therapy for patients who need dialysis as a result of acute kidney injury or chronic kidney failure, deep vein thrombosis and stress ulcer prophylaxis. So deep vein thrombosis prophylaxis you should have learned about this semester with Dr. Snowden. And then nutrition support, which you'll learn about in Patient Care 4. Here are the references in regards to distributive shock for today. We'll go back to the case questions now. So we have AF, he's our 72-year-old male. He went to the ED with sepsis as a result of pneumonia. He was hypotensive with a cuff pressure and an A-line pressure. His heart rate is 88 beats per minute. Upon admission, his lactate is elevated at 4.2. He's not urinated in the last 48 hours. His team would like to start fluid resuscitation. Which of the following is most appropriate to initiate at this time? The answer here is normal saline. The reason why normal saline is the correct answer is, remember that in order to get fluid resuscitation, you have to be either hypotensive or you have to have a high lactate greater than 4 millimoles per liter. This patient is hypotensive because their systolic blood pressure on the A line is less than 90. I would not rely on this cuff pressure as much. If you had a decent A-line pressure, you probably could maybe get away with not doing fluids. However, this patient is still hypotensive with the A-line pressure. This patient's lactate is also elevated. So that means that isotonic crystalloids are indicated. So the only isotonic crystalloid here is normal saline. As we discussed in hypovolemic shock, D5W is hypotonic. Albumin for septic shock should not be used, or sepsis should not be used unless adequate crystalloids have been given first, and hydroxyethyl starches are not preferred due to their adverse effect profile. Question 2, after you fluid resuscitated the patient in question 1, the patient remains hypotensive, what are you going to do next? The answer here is norepinephrine. And remember, norepinephrine is first line to administer for a patient who is in septic shock, has already received adequate fluid resuscitation, and needs a vasopressor agent to maintain their blood pressure with a MAP of greater than 65. Vasopressin is second line. Epinephrine is more of a third line agent, and remember dopamine is recommended last line, but it may be recommended particularly if your patient has some kind of niche bradycardia, because you may be able to benefit that patient by using the beta effect of dopamine. Case question 3. What's the mechanism of action and corresponding action of the choice selected in case question 2? So if you remember, we chose norepinephrine in case question 2. The answer to this question is that norepinephrine is an alpha-1 and mixed beta agonist, and that results in inoconstriction. If the answer was dopamine, then technically you could say either alpha-1 and mixed beta agonist or dopamine receptor agonist and diuresis for dopamine. Pure alpha-1 agonist goes more along with the lines of phenylephrine. However, phenylephrine does not cause bronchodilation because that is a beta-2 effect from remembering our receptors. And vasopressor receptor agonist, vasodilation. Vasopressin receptor agonist refers to vasopressin. However, vasopressin does not vasodilate, it vasoconstricts. So remember that the answer initially was norepinephrine, and that's why alpha-1 and mixed beta agonist inoconstriction is the correct answer here. If you have any questions, please feel free to email me. Have a great day.